Good morning, respected delegates, dignitaries, researchers, and one and all present here. We now begin day 3 of IPSCON 2025 with one of the most prestigious academic highlights of this conference, that is Dr. S.B. Pandey Oration. Dr. S.B. Pandey Oration is a distinguished academic honor instituted to celebrate the legacy of Dr. S.B. Pandey, an eminent pharmacologist whose pioneering contributions have significantly shaped the growth and direction of Indian pharmacology. This oration recognizes excellence in scientific thought, innovative research, and lifelong dedication to the discipline, and ultimately reflects current frontiers in research and therapeutics. The oration upholds Dr. Pandey's legacy by promoting scientific exchange and inspiring future generation of pharmacologists. To guide this prestigious session, I have the honor of inviting our session chairs, Dr. Pawan Kishan and Professor Nusrat Shafiq, to kindly take the dais and formally open the proceedings. Before we begin, I would like to briefly highlight the accomplishments of our esteemed chairpersons. We have Dr. Pawan Kishan, Professor and former Head of Department of Pharmaceutical Sciences and Drug Research at Punjab University, Patiala, an academician of high repute. We are honored to have Professor Nusrat Shafiq, Professor in Clinical Pharmacology Unit, Department of Pharmacology, PGIMR, Chandigarh. She serves as the member secretary of the Institute Ethics Committee and has played a pivotal role in establishing systems for serious adverse events reporting. She is currently a member of Institute of Ethical Committee, AIMS, Jodhpur. We invite our distinguished chairs to now guide the session by formally introducing our speaker, Dr. Anuradha Majumdar. May I invite Dr. Anuradha Majumdar on the stage?
Thank you. It's my pleasure to invite Dr. Anuradha Majumdar along with my co-chair here. Dr. Anuradha Majumdar is B.Pharm, followed by M.Pharm and PhD in pharmacology. She is an associate professor at the Bombay College of Pharmacy, Mumbai. She has been teaching and conducting research since 1999 and serves as chairperson of the CCSEA-approved Institute Animal Ethics Committee. She's former Dean, Faculty of Science and Technology, University of Mumbai, and has held several key positions, including member of the University Senate and Academic Council. Her teaching and research interests span physiology, pharmacology, toxicology, pharmacovigilance, and clinical pharmacy. And with these words, I invite her to take this esteemed oration. And the topic of the oration, I think, would be introduced by my co-chair. Semaglutide Saga, to fix it or not to fix it. So let me do it myself. So Dr. Anuradha is going to talk about one of the burning issues in current practice, research, everything. She's going to speak on Semaglutide Saga, to fix it or not to fix it. And without much ado, we think we can start with the oration. Over to you, Dr. Anuradha. Thank you.
Thank you, ma'am. Can I have the first slide? A very good morning to all. It's indeed my privilege, pleasure, and I'm humbled to be delivering the oration lecture in memory and in honoring Dr. S.B. Pandey. When I was trying to figure out what I would like to talk about, I decided not to speak on my research area. I decided to speak about a very hot and contemporary topic, which is the GLP-1 agonists, which are sweeping the market. So the talk has been titled to flex or not to flex, as you understand, in relationship to the muscle and the semaglutide saga. So this presentation is dedicated to and is a tribute to late Dr. S.B. Pandey. So on 14th November this month, while we were celebrating Children's Day, it was also the occasion of the World Diabetes Day. And Times of India had a very important article which stated that India's high diabetes burden is quietly breaking the nation's heart, which was from renowned cardiologist Dr. Ramakant Panda, who practices in Asian Heart Hospital in Mumbai and is renowned all over India. They say ICMR India B reveals that India's adult diabetic population rose from 32 million in the year 2000 to currently it's pegged at 90 million adults by 2024, which is showcasing a 10.5% prevalence. Recent studies reveal that roughly 1 in 9 Indian adults have diabetes, and most are undiagnosed. Majority of complications are silent but serious. Diabetic heart disease is under recognized consequence. Chronic hyperglycemia stiffens the heart and raises the risk of heart failure with preserved ejection fraction and other cardiovascular events. So coming to the promise of the GLP-1 agonists in type 2 diabetes and obesity. So GLP-1 and GIP receptor, we are aware of the pleiotropic role of the integrins, which are gut hormones and which act on myriad of organs and systems. So the GLP-1 and GIP receptor agonists enhance insulin secretion, suppress appetite, so it gives a feeling of satiation, and improves energy metabolism. Now, we started off, the market came with liraglutide, then came semaglutide. Semaglutide and liraglutide, both identified as GLP-1 agonists. Later came the dual agonists, which now is creating a lot of buzz in India, and that is tirzepatide, which is a dual agonist which acts on both GLP-1 as well as GIP. It is both dual agonists. And now is also development of retatrutide, which is under development, which is a triple agonist. So it acts on GLP-1, GIP, as well as on glucagon receptors to activate multiple integrin pathways, producing greater glucose control and weight loss than the single GLP-1 agonist like what we identify as semaglutide or Ozempic. So you can see it has, as I said, myriad of action. Some of the actions in CNS and the periphery are direct, some are indirect, both associated with the GLP agonism as well as the GIP agonism. So this is another reflection of the same. You can see the pleiotropic action. So over and above the pancreatic action, which is the one required for diabetes control and release of insulin, there is also impact on liver, prevents gluconeogenesis, action on gastric emptying and slowing it down, cardioprotective action, which is again, last month we saw some news on that from US FDA, and also action on brain. It improves memory, improves the cognitive function, which is something which we look forward to in the elderly. Coming to the GLP-1 agonist drug, semaglutide. The semaglutide, these are amino acid sequences, polypeptides, 31 amino acid chain with 18 fatty acid attached to it, and it has been promoted for type 2 diabetes. And now the current scenario, last month, US FDA approved it for even to prevent and protect against major adverse cardiovascular events, that is MACE. It has gained a lot of prominence as a weight management in obesity treatment. We have seen Karan Johar, who was known, the producer director, and now he looks absolutely thin and skinny, right? And the buzz in the news was that he is into Ozempic and semaglutide, right? So it is creating a lot of, people want to lose weight without really working on their diet and exercising, right? They think it's a miracle med by which they can lose weight. And so Ozempic, these are brands from Novo Nordisk. Ozempic is the drug which has been marketed for type 2 diabetes, Wegovy for chronic weight management, and Ribelsis. Both of these are subcutaneous injections, while Ribelsis has shown the innovative product is an oral formulation. Next, tirzepatide, Mounjaro, which is again, it has just been launched in March this year in India, and everybody is talking about Mounjaro. So Mounjaro is a 39 amino acid polypeptide. Both of them have long half-lives, both the semaglutide and tirzepatide. It is a dual incretin pathway activating drug, GLP-1 and GIP agonism, and has multitude of effect, a synergistic effect which gives greater glucose control, enhanced weight loss, possibly lean mass preservation, marketed under the brand name. Now, when these companies, this is by Eli Lilly, companies have marketed almost the doses are similar or slightly marginally higher for the obesity control, but they have marketed under different brand names. So here Mounjaro is marketed for type 2 diabetes and Zepbound has been marketed for chronic weight management. Yesterday Reuters had a news which stated that Eli Lilly, which is the innovator for Mounjaro, tirzepatide, has reached the trillion US dollar group, which was till now only attained by tech companies, the high-end tech companies which we know about. So this is the only pharma company to have the market value of more than 1 trillion, and this was the news yesterday. So you can understand why. Liraglutide, which was developed before semaglutide, has lesser efficacy. This is also a GLP-1 agonist, and it comes this is also from Novo Nordisk. It comes with the brand Victoza and Saxenda. Victoza again for type 2 diabetes, and Saxenda is for chronic weight management. This is a shorter half-life compared to tirzepatide and semaglutide. Now coming to pitching these three important molecules which are there in the market against each other. So semaglutide versus liraglutide versus tirzepatide. So as I said earlier, semaglutide, two brands, Ozempic, Wegovy, semaglutide oral tablets, Rybelsus, which shows absorption from the stomach. It is a caprylate based technology which helps in absorption, although it's so difficult to have polypeptides being absorbed without getting denatured in the gut. Tirzepatide comes with the brand names Mounjaro, Zepbound, liraglutide, Victoza and Saxenda. This is the only one in pink which I have highlighted, which is a oral preparation of semaglutide. Now this slide is heavy, but I have taken a lot of effort to summarize the market status and what's happening in this area, because 2025 has been a paradigm change when it now comes to diabetes and obesity control, especially in India. The global West has seen these drugs 2 years back, 3 years back, but we have got the approval this year. So coming to innovator company, as I said that Novo Nordisk has developed semaglutide, Rybelsus, which is the oral version, is also from Novo Nordisk, obviously. Liraglutide, earlier version of GLP agonist, again from Novo Nordisk. Tirzepatide from Eli Lilly, which is creating a lot of attention because of its dual nature of agonism. I have already told about the brands. Now when I'm saying FDA approval, I'm talking about Drugs Controller General's Office approval. In India, when did they get approval? Rybelsus got in 22, Victoza 2010, Saxenda 2023, marketed by Novo Nordisk, and semaglutide got approval this year in 2025, both Ozempic and Wegovy from Novo Nordisk, while tirzepatide, only Mounjaro, because as I told you, the doses are almost similar. It's only Mounjaro which has been approved by the Indian government, and it is approved for both type 2 diabetes as well as chronic weight control. Huge global market, and the Indian market is heating up, right? There's an incremental, exponential rise in the sales and prescription of these drugs. This is the projected compounded annual growth rate. Now coming to the patent expiry, because the patent cliffs play a very important role in how generic versions are going to come out into the market and what kind of collaborations will happen with the innovator company and the Indian companies. So expiry window of semaglutide next year, 2026, so many companies in the run. It will stagger to 2031 because of the oral formulations. So the improvement with respect to the route of administrations, there are other secondary patents. So the patent expiry goes up to 2031. 80% of Indian companies are vying to enter the semaglutide market. Reddy, Cipla, Sun, name it, they are there. They are trying to develop their semaglutide. Now 505(b)(2) submissions are also there with some changes in the route, in the formulation type. ANDA plans are underway because 2026, everybody is trying to be the day one generic to be launched in Indian market. Then the route, as I said, is subcutaneous. Liraglutide, earlier drug, already it has its, patent expired between 2024 and 2026. Secondary patents are also getting expiring next year. Companies like Biocon, Glenmark, they've come out with biosimilar versions. So biosimilars are either in the stage of launching or going to be launched. You will find liraglutide formulations which are biosimilars in the Indian market, costing much lesser than what the innovators' products are. Then coming to Rybelsus. Rybelsus also oral. People are, that is an extended patent which goes up to 2035. The drug company always, the innovator, the sponsor company tries to extend their monopoly rights over the product. So there are Indian companies who are trying to file 505(b)(2) in that for oral formulation of semaglutide as well, Macleoids being one of them. So you see 505(b)(2) with enhanced bioavailability and oral tablets daily. That will become more patient compliant and friendly because subcutaneous, still there are blocks for patient to take subcutaneous formulations. Now coming to Mounjaro. As I said, India has approved Mounjaro, right? There are companies like Biocon and Dr. Reddy's which are trying to partner, right? And already Cipla has partnered with Eli Lilly. I will come to that. These are all news between and happenings and updation between this year September, October and this month November. So till now tirzepatide, no 505(b)(2), very well patent protected, and as we are aware that it is a subcutaneous formulation. So this slide sort of says that all Indian companies since the last 1 or 2 years and this year are running towards these 3 molecules so that they can also get a chunk of the pie, that is the market associated with diabetes. We saw how diabetes has, the prevalence is so high, and also obesity. And so who is under the focus? Semaglutide, tirzepatide and liraglutide, the 3 molecules. Although the main protagonist of this presentation is semaglutide, I would also pitch it with the other heroes in the fray, that is Mounjaro, tirzepatide and also a bit on liraglutide. So coming to the patent cliff which awaits, right, the molecule expiry timeline. So you can see the 100 billion plus patent cliff navigating GLP-1 expiry. Liraglutide, the first descent, okay, it is this next year almost all the patents would expire. So as I said, biosimilars are in the market. Then semaglutide, the main event next year, all companies are gearing up for it and we have to brace for it, right? Primary patent expiry 2026, but crucial method of use with respect to oral formulation still under patent and protected till the next decade. Tirzepatide, the next summit, and I'm sure, as I told you, Eli Lilly hitting the $1 trillion core group of exclusive companies, that just shows what the market is going to pan out to be, right? So tirzepatide is the next summit. The expiry of the patent is 2036 to 2039. So it has become so popular in the West. The other day I read that even in Walmart, the Walmart pharmacy is giving out like, like retail Zepbound, and Zepbound is for obesity. So a citizen of US can go and get Zepbound from the Walmart pharmacies. Earlier it was much more stringent through the other, the government associated, pharmacies and not from Walmart. So now this you can see already fake versions and counterfeit versions are there in the market and US FDA is warning about it. That just shows how it has hit. Now last month there were a lot of headlines, news headlines, and those were, for example, Times of India, fat loss drug Mounjaro, now India's #2 pharma brand. You can see here Economic Times, obesity lab, India becomes ground zero for weight loss, right? Eli Lilly's obesity drug, India sales hits a sweet spot. Now sweet spot not literally, not metaphorically, but with respect to the business, right? So It was launched in March this year, and in September, it is second in line compared to Augmentin of GSK, which we know is an anti-infective combination. So Mounjaro sale only in the month of September was close to 80 crores, right? And the high unit price of Mounjaro between 14,000 to 27,000 per patient per month is a major driver of its value despite lesser volumes. Today, DCGI says we should look into biosimilars and biologics. Why? Because compared to the volume-based business, the government is looking that you go for value-based business, right? So, just see the strategy of big pharma international companies. Eli Lilly has already tied up with Cipla, and it's going to make a tirzepatide brand called as Urpic. This is a very, very recent news in the same dose range, and the price is aligned with that of Mounjaro, right? But here the brand will be Urpic. Why? Eli Lilly's ground force is much lesser compared to Cipla's ground force and logistic, networks across India. So Eli Lilly is leveraging on Cipla's strong distribution across India. So the Lilly-Cipla collaboration underscores how weight loss therapies are becoming major strategic drivers in the Indian pharma landscape, bringing global innovation and local reach together. Earlier, innovation companies would restrict their own brands. This is a strategic partnership, which is win-win for both Eli Lilly as well as Cipla. And although Cipla is not the innovator, it is going to release its own brand along with Lilly into the Indian markets, and we expect it by next year, 2026. Another important development happened last month. US FDA has approved Rybelsus, okay, for, it has expanded its indication beyond type 2 diabetes to reducing risk of heart attack and stroke by lowering inflammation in people with or at risk of cardiovascular disease. So that means this has got an extended indication, right? And there were two trials conducted, very famous trials. The SOUL trial, which proved oral semaglutide reduced the major adverse cardiovascular event by 14%. The SELECT trial, which showed that injectable semaglutide reduced the major cardiac MACE by 20%. See Rybelsus. Why Rybelsus is better? Because it is an oral formulation. So compliance is better. It will be more accepted by the populace. So the Food and Drug Administration has approved oral FDAs, that is semaglutide, and now we have semaglutide, which is not only prescribed for type 2 diabetes, but also to prevent cardiovascular and abate cardiovascular risk, including in those who have not previously had a cardiovascular event. And Novo Nordisk has built a robust patent portfolio, as I told you, with respect to its gut absorption using caprylate, polymers and other delivery systems. Now, semaglutide landscape in India. The key player I told you, 80%, India is emerging as a semaglutide manufacturing as well as export hub aligned with the global metabolic therapy demand. So the innovator companies may be headquartered in the Western world, but they are planning to manufacture their products even in India, and maybe also have, as I told you about Cipla, have separate brands meant for only the Indian market. So it's growing, and the Indian anti-obesity drug market is growing. You can see the peak is rising. Now, semaglutide patent dispute between Novo Nordisk and Dr. Reddy's. This was also, coming up this year. So you can see it's in the Delhi High Court, and Novo Nordisk had filed a lawsuit against Dr. Reddy's Laboratories but you can see the Indian government's take. So Indian government, has a stance which was also there with several anti-cancer drugs, right? For example, Glivec, we have seen it in the past. So the patent evergreening and export exemptions, which comes under the Bolar provisions, Indian government wants these drugs at reasonable prices, affordable prices, and more accessible. So Indian government is very pro the Indian companies coming out with their versions, and that will apply even in semaglutide, which is coming out in 2026, the generic versions. Now, GLP-1 agonists like semaglutide or dual agonists like tirzepatide or the triagonists which are in the developmental phase will sweep the obesity and type 2 diabetes market. So things will change. The landscape is going to change in the future. So should we be vigilant? Absolutely yes. Why should we be vigilant about it? So if you see the package label, the labels of these products, right? The boxed warnings for both cases, Ozempic and Mounjaro, is thyroid C tumors, but these are more found during the preclinical studies in rodents, right? Not very rare or not encountered in humans as yet. There are common side effects associated with GI tract, other warnings. So while both semaglutide and tirzepatide offer significant metabolic benefits, their prescribing information emphasizes vigilant monitoring, especially for gastrointestinal, thyroid, and volume status risks, hemodynamic kind of imbalances. So another subpart of my talk is to flex or not to flex. Flex the muscle or not to flex the muscle. The dichotomy of evidence on semaglutide. There are contrary evidences. One very important evidence is that this was a retrospective study, 2 cohorts. The cohort where the elderly diabetic patients were exposed to semaglutide, that is Ozempic, for 24 months, that is 2 years. There was presence of sarcopenia up to 27.7%, which is a significant percentage. So we should look into, when the Indian citizens are going to expose to the drug, we should have very robust pharmacovigilance because millions would be taking these drugs. Already lakhs must be already taking the drug. We need to follow up and have a pharmacovigilance process in place. Molecular basis for semaglutide acting on thyroid changes because it is acting on the cyclic AMP, PK signaling pathway, and it's known to act on the TSH suppression, and it can cause C cell proliferation, the thyroid cells which are known to release calcitonin. Now coming to muscle, semaglutide improves glucose uptake in skeletal muscle by upregulating GLUT4 activity, and weight loss can cause relative lean mass reduction, although functional muscle strength is usually preserved. It's acting via the AMPK pathway, and it is having a catabolic phase during rapid weight loss. So this is the impact. Further, it has been seen that GLP-1 agonists, they cause effective weight loss, but also 25 to 39%. They are causing fat-free mass reduction, which is worrisome, right? Over 36 to 72 week period. The magnitude of total weight loss rather than the direct drug effect likely driven by its muscle loss. By comparison, non-pharmacological diets cause only 10 to 30% of FFM loss. Age-related muscle loss, lean body mass loss, is hardly 0.8% per year. So GLP-1 induced loss is several fold higher. Now here also you can see a dichotomy, a paradox in the evidences which are coming forth. Some are preclinical evidences, some are clinical evidences. Quickly, semaglutide reduces cardiomyocyte size and cardiac mass in lean and obese mice. GLP receptor agonists, attenuates chronic liver disease, induce skeletal muscle atrophy in diabetic mice. Oral semaglutide induces loss of body fat mass without affecting muscle mass in patients. There's a clinical study. This is something which I was talking about. Chronic semaglutide treatment in rats leads to daily excessive concentration dependent sucrose intake. A case report of semaglutide induced sarcopenia causes fatigue in older adults, right? So a lot of dichotomy in the evidences which is coming forth. So the negative evidences, emerging safety concerns, sarcopenia, and cardiac atrophy. These are papers which are associated with preclinical on rats and on heart muscle in mice and human cells. So here you can see that it suggests a systemic muscle remodeling effect of semaglutide, remodeling, restructuring, what we call as re-engineering, influencing both the skeletal and cardiac muscle system. This report, which is a clinical report, it's a case study which says a 74-year-old male, 2 years treatment, semaglutide has accelerated sarcopenia and emphasizes the need for baseline muscle evaluation and rehabilitation support. In the earlier slide also I mentioned that there needs to be protein supplementation, weight training, and those kind of things to build the muscle. Positive cardiac outcomes, semaglutide in heart failure with preserved ejection fraction with obesity.
Sorry to interrupt you, Dr. Anuradha.
5 minutes.
Okay, please.
Yeah, I can see 5 minutes. I'll wrap up in 5 minutes. Yeah. Semaglutide in patients with heart failure with preserved, I said this is a beneficial action, which is a clinical study which has been depicted in a paper. This is the same study showcasing the results, right? So this is a very positive result showing, and that also probably resonates with the US FDA approval for its protection for cardiovascular events, right? It is preserving lean mass is what another study says. Okay, this is also on patients. It achieved fat specific weight loss, sparing skeletal muscle and prevents sarcopenia, right? So again, a contrary, but these are all clinical studies. The others were more towards preclinical and clinical in the elderly or sporadic case studies. So this is a summary of the positives and the negatives. So here you can see the positive preclinical study. It attenuates liver disease, which is induced by muscle atrophy, and it is good. Mechanistic insight is via the SIRT1 PGC1 alpha pathway, so it must be acting on the mitochondria, right? Clinical trials, it causes loss of lean, significant fat mass reduction without loss of lean muscle mass. While the negative cautionary findings is prolonged therapy in older adults associated with accelerated sarcopenia and reduced functional capacity, report of fatigue, this is clinical in older patients, fatigue, weakness, muscle loss improving after dose reductions and resistance exercises. So how do I summarize the semaglutide saga? Dual nature of semaglutide, so it demonstrates fat selective weight loss, metabolic improvements, and there are also evidences to show risk of sarcopenia is reduced, functional decline, no sorry, the evidence is that risk of sarcopenia is enhanced and functional decline in older or long-term users. So there are preclinical and control trial evidences, real world data which highlights fatigue and weakness. So it's very important to understand that a balanced use requires careful monitoring, proper nutrition, resistance exercises to maximize the benefits while minimizing the muscle loss. To flex or not to flex, impact on muscle morphology and physiology, and there is a need for more evidence when it's in the real world settings in India, which starts from next year, and even the the innovative products are already in the market. This is the future coming soon. Orforglipron, this is also from Lilly. You can see here the Pfizer products have not continued. This is in phase 3 and successfully demonstrated efficacy with respect to oral semaglutide. And this is the future, right? These are not polypeptides. These are small molecules. So it is representing a major shift in peptide to small molecule innovation, enabling easier manufacturing, lower costs, and broader scalability for global obesity and diabetes treatment. So things, there is a lot of research going on and innovation in this sector, and we'll soon see non-peptidic small molecule products in the market in the future once it is approved by US FDA and our DCGI. So these are some of the references for the, the benefits and the risks. I would like to acknowledge some people who were part of my journey almost for 27 years. So I extend my heartfelt gratitude to the esteemed Indian Pharmacological Society office bearers and the jury of Dr. S.B. Pandey Oration Award. Thank you very much. I'm humbled, and it's like it has been such a honor and treat for me to come here and present in such a honorable esteemed setting and august presence of you all members. I would like to thank my guides. Dr. C.T. Chopre, I did my master's from him. He was my first guide who made a dramatic change in my approach to research from Nagpur. Dr. Emin Saraf, who has been my master's guide. Dr. Professor Kulkarni, he is there. He has influenced me in all phases when I was in Nagpur, when I was in Mumbai, in all phases. Thank you very much, sir, for all your support and mentoring. I would like to thank Professor Anil Kumar for inviting me here. My mentors, seniors, colleagues, who constantly they supported, their wisdom, encouragement has shaped my growth as a researcher. I also acknowledge my students. They have been the main strength. They have been the reason that we always feel young and happy in our ecosystem of the campuses, and the support they provide for everything, including fine-tuning the presentation. I thank all my students in the past and the current, and whose curiosity, dedication, and enthusiasm continue to inspire me even today. Very important, I was born at a time when I have seen and witnessed the quiet and the content of the 1980s and 1990s, and after 2000 I saw Google, I saw the, the boom, and thank you very much for having that, this as well. The achievement is a reflection of my collective, guidance of people. Thank you very much. Thank you. This is in one of the events in my lab. Some of my research students and some of the faculty are also there. Thank you very much.
Thank you, Dr. Anuradha, for your wonderful presentation, throwing the insight into the potential of semaglutides and their trivial issue regarding to their efficacy and safety with respect to side effects, whatever they are to be encountered in the coming time, but also showing the potential market for the drug, as there is a lot of epidemic, especially with respect to India, the epidemic of obesity and diabetes. So it's a wonderful presentation. Thank you once again. So as it's a oration, I think rather than having questions, we can have some suggestions and comments if required, if acceptable.
Yeah, I think we can have a quick comment maybe.
Please, sir.
So the evidences which has come in, sir, is in 2 years of regular intake of the drug. So probably they will have to, because if you go to the Uppsala Monitoring Center meta-analysis and this, nothing is there. I had to literally dig for the information because these are high value products in the market. So UMC, I tried to get some data. CIOMS, I tried to get some data. So probably when it comes to India, like Madam is from PGI Chandigarh, probably, and from other hospitals, they need to have some kind of focus on GLP-1 and the dual agonists in Indian population.
Because there are some reports when you stop taking the drugs, again you
gain
obesity
weight.
will come back.
Yeah.
And that's one issue. Other issue is about the cost effectiveness. And recently even Donald Trump has allowed giving $1,000 to those who are buying these drugs as a safety money to buy these drugs. They are very expensive.
Yes, very expensive. But liraglutide, once we have the generic version, sir, I think that cost will be much, much reasonable. But whether it is Mounjaro or Ozempic, the costs are formidable. 2026, semaglutide also, I think the costs are going to come down.
Thank you, sir. Thank you, Dr. Anuradha, for such an erudite presentation. And thank you, sir, for bringing up that very, very important comment, because I would like to inform the gathering here that we have evidence from the clinical trials which have already been conducted that the moment you stop the drug, the weight starts creeping up. And if you see the number needed to treat and number needed to harm, I think the balance would shift towards it's very interesting that you pointed out that the drug is being launched rather than approved. That's how our it has become so market driven. So it's very important that we understand all the developments in the market area also, which is so beautifully brought out. But having said that, I think it's very important to keep in mind all the important points that sir raised in the end. And with this, I think we can conclude this session. And thank you very much.
Thank you.
Thank you, ma'am. I request our session chairs to please felicitate our orator with a token of appreciation.